All right. Welcome, everyone. We will get started. So good afternoon, everyone, and thank you for joining us today for our third workshop for this rulemaking. I am Amelia Boyd, and I am the program manager for the commission and the organizer for this webinar. This meeting is being recorded and will be made available sometime this week. The documents which will be discussed here today are available on our website, which is wmc.wa.gov. Attendees, you will be muted unless you are speaking. We'll use a raise your hand situation to unmute you. And if you have a question, just use the raise hand function or put your question in the chat. So at this time, I will begin the roll call of panelists and staff. When I call your name, please introduce yourself. We will start with Marlon.
Good afternoon. My name is Marlon Basco. I'm a policy analyst with the Department of Health, supporting Amelia with rules work.
Thank you. And Heather?
Yeah, good afternoon. Heather Carter, Assistant Attorney General and Legal Advisor to the Commission.
And then Kyle?
Good afternoon. My name is Kyle Kiernan. I'm the Executive Director of the Medical Commission.
And then Dr. Lyle?
Good afternoon. I'm Sarah Lyle, a commissioner with District 2.
And then Dr. Ventura?
OBGYN.
Thank you. And then Dr. Domino, if you would introduce yourself and then begin the script.
Hi, I'm Karen Domino. I'm chair of the Washington Medical Commission. I'm also an anesthesiologist. So, good afternoon. My name is Karen Domino, and I'll be the presiding officer for this rules workshop. Today is Monday, January 23rd, 2025, and it is now 1:35 p.m. The meeting is being held via Teams webinar and in person in the Department of Health in room 166 located at 111 Israel Road Southeast in Tumwater, Washington. The rule being discussed today is the use of nitrous oxide in office-based surgical settings. The CR 101 or pre-proposal statement of inquiry was filed on May 17, 2024 as WSR number 24-11-104. For our draft language discussion today, we'll be reviewing and discussing revisions made to the proposed section WAC 246-919-603 based on suggestions from the previous workshops. The draft language for this new section is included in the packet and will also be displayed on the screen. So we will discuss this language. Is that correct, Ms. Boyd?
Yes. So today our focus is going to be on reviewing the language that we have. We will discuss the revisions from the previous workshops. And then we do have one written comment. There have been no new written comments posted to this rules site, and I haven't received any other written comments. And then let me check one more thing. So we will go through this, and we, by the end of it, the commissioners will need to vote whether to move the language we create today forward to the next step in the rules process, which is the CR 102. Let me pull up a different, I need a Word copy, this section. Hold on just a second. Figure out where I put it. Here we go. So as Dr. Domino mentioned, this language is available in the packet, but we will be working off this Word document. So first, I want to talk about a concern that Dr. Lyle has about this section here. with basic life support, pediatric advanced life support, and the advanced pediatric life support. So we talked about this section during a previous workshop. We've had 2 other workshops for this rule, and it was changed. I can find what it said previously. I think it did have adult life support before. I think we changed it last July.
Yes, it was ACLS, and
Mhm.
that's something that we had written in. However, the feedback from other commissioners as well as others in the at the workshop were that this in ACLS is not required for use of nitrous oxide in the concentrations used, which is no more than 50% nitrous oxide, which is a sub-anesthetic dose by itself. It can cause a little sedation and make you feel weird, but that it would be that the dentists don't have this requirement. I think the PALS and the APLS, I don't know the difference. I only had to take PALS when I used to work with kids. But I'm not sure isn't BLS. I mean, maybe someone who is pediatrically oriented, but it says pediatric advanced life support. I mean, that was like lines and intubations and other things that I recall. So I'm not sure why that got left there. I think it's just from not eliminating that it from the rule. So if there are any comments about it, we were just trying to make it consistent with what is going on with the dentists.
So the one on the right is from the very first workshop. And then the one on the left is the one we're talking about today. Go ahead, Dr. Lyle.
So just to clarify, the dental rule has BLS as the resuscitative minimum, and they use 50% as well. Is that fair?
I know they use the 50%, and I've been told that I haven't looked at it, but I know our attorneys had.
So
I
it
mean,
seems like that would be reasonable to just leave it at that. And then the language here is
strike the B
like,
and C from it.
yeah,
Yeah.
such
I mean,
as
did anyone check that? The dental rules, I mean, we took this off of what we were writing, kind of a combination between dental and the office-based rules that we have from the medical commission.
I think we did check it previously, but Heather, if you could comment, I will try and look.
Yeah, if we
Yeah.
could look it up again, just to be 100% sure, because I don't see why we need the PALS or APLS in there.
I can confirm that. I know, so there is a rule requiring all dentists and staff members to have BLS. And then they have different permits for levels of sedation that require, some of them require, like their pediatric endorsement requires PALS, but I don't think everyone's required to have PALS for nitrous, because there isn't a permit required for dentists for nitrous. That is allowed for anyone. So I can double check, but I believe it's just the BLS for nitrous.
Okay, thanks. That's my understanding from before, but I thought it was worth double checking. Now that Dr. Lyle pointed out that we still had the PALS and APLS.
So do you want me to edit this to be?
Just take out PALS and APLS. I mean, it's not.
I can delete that, and then I would just change it to and make this a period.
So do you just want them to have BLS? So then if you do, then I would
Take out the
remove
but not limited.
such as, and
Yeah.
put that, yeah.
It says advanced resuscitative techniques and that basic life support. I'm not sure it's an advanced resuscitative technique other than just saying basic life support.
Do we want to just say that who is certified in basic life support,
Yeah,
BLS? Okay.
So you are removing B and C, right?
Correct. So let me see, well, let me save this and then accept the change and then you'll be able to see how it reads.
And I did just find the dental rule. It's 246-817-740 requires that the dentist must hold a current and valid BLS certification.
Thank you, Heather. So now that will just read at least one healthcare practitioner must be present who is certified in basic life support BLS.
and let me say the reason why we put more than one healthcare practitioner is we didn't want the person doing the procedure to be resuscitating the patient if needed, right?
Let's see what this up here. So your intention is to the physician performing the procedure, you don't want them doing basic life support.
Well, they'd have to stop the procedure if they need to do it, right? I mean, so I don't think you should say, we were trying to leave it flexible. Well, partly is there's somebody recording vital signs. We asked for that, I think, in this, from what I recall.
From the wording now, as it stands out, it looks like you have to have two providers in place, the one who provides it and the one who's doing the procedure. You may
Yeah,
stop doing the procedure, but there should be somebody, at least according to the wording at this present moment.
that was the whole point, that we wanted two providers. When they stop the procedure to help, that's great. But we don't want a single provider, that we don't want the doctor or PA to be doing both. They can't be monitoring the patient, for instance.
So do you need to make any more changes to this small Roman numeral 2?
Well, can I just clarify the last statement? Because from what I'm reading, unless I'm wrong, from what I'm reading, it appears that the physician must be capable of resuscitating a patient from deeper. And then on 4, it says the physician performing the procedure must not administer the nitrous oxide or monitor the patient. So when things are going bad, he can stop the procedure and then take over if he's the one who's been trained for the basic life support.
Yes, correct.
Okay, thank you.
Because these are mostly short procedures that are going to be done, and they could stop and do that.
All right, so are we good with Roman numeral 2 now with this edit?
I mean, let me just say, we felt that if someone in the office is certified in BLS, we don't necessarily have to have the physician to have that. I mean, we copied this thing, capable resuscitating patient from deeper sedation levels, but I mean, you take away the nitrous, breathe oxygen, right? They breathe oxygen, you just change that. They can hold a jaw thrust, someone could do that, that's a BLS thing. And they want to make sure, they could tell someone how to do that. And they want to make sure that the vital signs are monitored during the procedure. So unless you think we should make the physician have BLS, but really, do you think urologists and gynecologists who will use this a lot, or radiation therapists should be using, have to be BLS certified as opposed to a nurse, as an example?
Just
Do
need
you guys
one
have
person
any
in the
comments?
office.
I mean, just trying to save people's time. I think a nurse is fine for BLS.
Yeah, I agree with that. Not to overburden the whole office getting into BLS. I think just one provider will be good enough.
I mean, it would be so rare to have an issue.
I agree.
Okay. So, and then the next piece, this Roman numeral 5 was changed after the last workshop, which was in October. So if
I
you
mean,
have
that
any edits for that.
looks good. That's the whole point.
Agree.
Okay. Right along. And if you have any questions or comments, even the audience, over things that we're sort of going past, we can come back to those. Because right now we're just looking over what was revised since the last workshop. I think there's one more place. So this was a big ask at the last one, that we put an age limit. So this is the change from the last workshop.
And I mean, I thought it was fine. I think initially maybe it was age 2 or something, but the reason why, the thing is that babies don't have teeth. Okay. So in the dental offices, if you have someone who's even a year old, they have like a couple little teeth, they're probably not going to be having this done in a dental office without probably, I mean, if they anyway, so there was controversy over kids between age 1 and 3. I think, they, as I mentioned, they can have a higher anesthetic. They have a higher anesthetic requirement than do adults, and the anesthetic requirement goes down as you get old. So to me, the ones I was more concerned with are older people. But because it may be an anesthetic in them, but in someone, I thought for other safety reasons and for use, familiarity with working with little kids, people recommended the 3 years. And then that other statement. I mean, patients who are younger than 6 have special needs, have airway abnormalities, probably need an anesthesiologist or nurse anesthetist to be providing adequate anesthetic. 50% nitrous is not an adequate anesthetic. And those are all our issues. So, Amelia, there's someone named ES.
I am working on it. Miss Savila, let me allow your microphone. You should be able to go ahead. You are self-muted, according to what I see.
Oh, how about now?
Very good. We can hear you.
Okay. I'll start over. My name is Yoan Savella. I am the Director of Public Affairs with Mount Baker Planned Parenthood up here in Bellingham, Washington. I'm here today stepping in for Rachel Kunze, who's the Public Policy Manager with Planned Parenthood Alliance Advocates. She's out sick today, so just wanted to make a comment about Roman numeral 9B, the reference to having special needs. Just a few points there. It's a little concerning that they would have to consult with a parent of a minor with special needs before being able to administer nitrous. The term special needs is overly broad and unclear, and the groups affected are not clearly defined. The meaning could include any number of various difficulties, such as physical, emotional, behavioral, learning disabilities, or impairments. And just want to point out, in Washington, minors have a constitutional right to access birth control and abortion without parental involvement. So as written currently, we're concerned that it may lead to infringement of that right and ability to access confidential care. And just pointing out again that this is a disability rights issue. Having an intellectual disability does not automatically preclude an individual from being able to give informed consent, and mistaken assumptions about patients' abilities to consent to services also reduces access to care. So hoping we can get a change there.
Aren't they emancipated minors and can consent themselves?
In this case, I think we're referring to folks who may not be emancipated. Just anyone in Washington, minors have a constitutional right to accessing birth control and abortion care without parental involvement.
I mean, we could get rid of B. I'm happy to do that. Airway abnormalities could be an issue, but it would be unlikely, you know. I mean, don't yours give a paracervical block for the cases, right? They don't necessarily need any sedation for those procedures. And yes, you want to maybe have the nitrous oxide to, as we don't use it much in anesthesia anymore because it is a greenhouse gas and it's contributing to global warming. But I'm happy to get rid of that.
Yeah, that would be great. That was the only comment we had, so that would take care of it.
Does anyone have any concerns over getting rid of that? I mean, special needs was a weird, it was very vague.
Was this section about pediatrics specifically, because the discussion must include reasons why the pediatric patient was?
Yes, it's supposed to be about pediatric.
Okay.
Talking to the parents.
Okay. I don't know if we need to put in something is not able to give their own informed consent. It seems like just omitting it is fine, but I appreciate the comment because it does infringe on adolescents accessing care that they're entitled to without their parents being involved necessarily.
You could add that, Sarah, if you want to provide language to make it clear.
I'd rather leave it vague.
I just always thought they were emancipated minors. They could give consent, but yeah. I mean, I don't.
I think A and C, or A now B, would cover I think the issues that are trying to be covered here, and otherwise an adolescent accessing reproductive health care where nitrous might be helpful for them is just assumed to be okay here because they've consented as they're able to do. So there's no reason to add any special language. I think it's already inherent in the practice and the law. Does anybody see that where we'd get tripped up with that? if we didn't add specific language? Can you scroll up just a second, Amelia? My other computer died. I can't see it. All right.
So once we're done with that, I want to go back to that earlier section, just beyond the pediatric issue.
I think we're good.
Can we go up to the monitors?
What section are you wanting?
Yeah, the one there, it says the following equipment must be available. Suction equipment, yes. Portable oxygen delivery with vets for resuscitation in addition to the device. Blood pressure cuff, yes. The stethoscope or equivalent monitoring device. I'm not sure. They really need a pulse oximeter. I don't know when you, I mean, a stethoscope, if you have a comp, you know, if they're, I mean, we don't even use stethoscopes except to listen to people's heart, lungs. You know, in the old
So-
days, they'd have a, you know, a little thing you put on the heart, you know, chest to hear them breathe, and that now there's pulse oximetry, which I would
So-
think in old people, you might want to use that. So it would be good. So I'm surprised we don't have pulse oximetry in there.
So do you want to change stethoscope to pulse
Yeah,
oximetry?
get rid of that. Yeah.
You're gonna have to spell oximeter for me. It's not a word I use
X
every day.
OXIMETR. I'm not sure if there's any equivalent monitoring.
So just leave that
Just
out
get rid
too.
of, yeah. That just measures their oxygen saturation. Not an issue, I don't think, with most people, but with the elderly people having urology procedures, it might be. And it is a standard monitor. Did we get rid of EKG? Did those come out earlier? Is that what happened?
I think so.
You
We
know?
did change this at some point, this section a little bit.
I mean, I think EKG is optional, but I think the pulse oximetry is not. Because I think originally we wrote it with EKG and pulse oximetry.
I think that got changed at some point. And maybe it's
Yeah.
in a different spot. I just can't get to it right now.
No, I think there was some pushback about it because people may not have ready access to EKGs.
Okay, I do remember that.
Yeah. But pulse oximeters, I mean, you could buy one in your house, you know, they're simple things. And if you're going to use this, you should have it probably. Then that can tell what the heartbeat is, if it's regular or irregular, and what their oxygen saturation is. So.
Okay, so I'm just gonna change this to oximeter.
Yeah.
So it's similar to the others. Okay.
Yeah.
So are we good with this change? Dr. Ventura
Yeah.
and Dr. Lyle? Thumbs up. All right. Okay, so we've talked about this piece already, and I think there's one other There one other. Okay, it's 3. So there were some revisions made to this section 3. Let me know when I can move along.
Yeah, for me, you can.
So here's all the criteria.
That looks okay to me.
Good to me.
Yeah, they
Yep.
seem okay.
Okay. That is the end of this new section. So
And
we did.
we
Go
have
ahead.
training in there too, because they obviously need training. There are a whole
It's at
bunch
the
of
top.
situations like you can't use nitrous because it goes into dissolves into the night. It will go into air-contained spaces and expand it. So there are issues with that. I'm assuming they have a training requirement with this. I thought we put that in.
That's at the top, I think.
Yeah.
And scavenging was also mentioned.
Yeah, we wrote scavenging it. And do we have the storage too? Because I know
Yep.
PHP had a real issue with abuse because it is um, it inhibits methionine synthetase, and people end up having a anemia basically, and they get basically neuropathies from it, and it is not a good drug to be ingesting, or breathing.
Where did we put that?
I thought it was at the top.
We had it in there at one point. Let me go.
It's
We
there.
look on a different screen.
It says it's rules for who perform surgical and use nitrous oxide. Okay, well, I thought it was in there, but because it was originally, but things have been removed and changed.
Mm-hmm.
Okay, let me look at another screen.
Yeah, it's in number I. I don't know why that's number I.
Oh, it's a
Position.
subcategory under
Okay,
C?
yeah. Yeah.
Yeah.
Mm-hmm.
Yeah, there's the CME.
Okay.
And then we go on to the BLS resuscitation.
Then there's this documented plan. Records. Vital signs. The following equipment. We talked about that. Then this is about the
kids.
pediatric. Oh, here we go.
Here we go, number X. And then
Yeah.
number X.
Storage.
Yeah, stored.
Yep.
Yep.
That looks good to me.
Yep. I agree.
Okay, so we only made a few small changes. And then we do have one written comment that was in the packet. Let me, unless there are any other comments from the audience. I don't see any hands raised right now. So we did get this comment from Wisma. They supported the rule as was drafted in the packet. So this is more informational than anything else. Thank you, Billy. So Billy Dickinson is here. She's from WSMA. So, all right, that was the only written comment we received. There are no new written comments on the website for this rule. And so we get back down here. So Dr. Domino, we can, unless there are any comments or questions about any other portion of this draft language that we've talked about today, we can move along to the next part of the script.
Okay, there are no additional questions, is that right? We've passed
Right.
that?
Mhm.
All right, well, thanks for your participation. Commissioners, I request a motion to approve the revised draft language discussed today and presented at Commission's March 14th business meeting, along with a recommendation to proceed to the next step in the rulemaking process, proposed rulemaking or CR 102.
So
So,
moved.
can we vote? We have 3 of us. We approve.
We approve.
Yes.
All right. Well, thanks so much. Ms. Boyd will now discuss next steps and provide contact information.
All right, just a second to get that pulled up. All right, let's move through this quickly. Okay, so here is our proposed rule development timeline. Hold on just a second. This never shows the way I want it to. And so we are on schedule to meet this timeline. Like Dr. Domino mentioned, we will present this at our next business meeting, which is scheduled for March 14th, to ask to initiate the CR 102. And then the hearing is tentatively scheduled for August 22nd. And then there will be a 5-week period prior to that hearing where we will accept comments on this rule. And the draft language which will be presented is the one that you've done today. Excuse me. And then so that is our next steps. And then here is our contact information. And like I showed earlier, this rule does have its own site on our rules page. So you can go and provide comments there. And it will be checked before the next business meeting on March 14th.
Great. Is there anyone else who wishes to comment? Well, if seeing nobody, if there's no one who wishes to speak, I'll now close the workshop. Thanks everyone for participating.
Thank you, everyone.
See ya.
Thank you. Bye.
Bye-bye.
Thanks, bye.